Assalamu alaikum students and welcome to your continuing series of ophthalmology clerkship video sessions. Today we will be talking about lid malpositions and this is our second differential of the ocular surface and lid anomalies theme. Today we will be talking about three different types of lid malpositions. Two of them have something to do with the lid margin and one has to do something with the upper lid. The ones with the margin anomalies are ectropion and entropion, and one where the issue is with the upper lid, it's called ptosis. I'm sure you've heard of these terms before, in at least entropion and ptosis, entropion in the context of conjunctivitis, specifically that caused by trachoma. And ptosis, I'm sure you have done at least or heard of at least somewhere during the last 3.5 years of your medical school career. So before we go on and actually talk about these disease entities, we need to establish certain norms and look at certain normal features. And this is basically a picture that shows the position of the upper lid, the lower lid, and also the punctum of the eye. If you look at the upper lid covers the superior limbus. The limbus is the transitional zone between the cornea and the sclera. So you can't see the superior limbus because the upper lid covers the upper 2 millimeters of the cornea, thus hiding the superior limbus. The lower lid rests just at the limbus. So you can see the inferior limbus because the lower lid is just resting there. The puncti, the part where the drainage system of the eye begins, are flush against the eyeball. They're located at the medial ends of the upper and lower lid and about here, and they're flush against the eyeball. By flush against the eyeball, I mean they oppose the eyeball so that they can efficiently pull tears away from the eye into the drainage system. The third thing I would like you to look at is the way the lashes or the cilia are directed. The lower lid lashes are directed downwards and outwards. The upper lid lashes are directed upwards and outwards. So this is the line of the dotted line showing you the approximate position of the superior limbus and how it is obscured by the upper lid because the upper lid covers the upper 2 millimeters of the cornea. The lower limbus or the inferior limbus is visible because the lower lid rests just at that point, and this is where the puncti are, and they are flush against the eyeball. And finally, we have talked about the position of the lashes. So this is the structure of the lid. It is covered by skin interiorly, which has the cilia or lashes as its appendages. They are associated with gland of Zeiss or Zeiss, and they can be involved in certain inflammatory conditions that we've already talked about. Underneath the lid, you have layers of subcutaneous tissue followed by the orbicularis oculi muscle. This is a really important muscle because it helps shut your eye properly. It is involved in both the etiologies of ectropion and entropion. Beyond your orbicularis oculi, you have your fat and then your neurovascular bundle, followed by levator palpabris superioris and Muller's muscles. Levator palpabris superioris elevates the lid. It is a skeletal muscle supplied by the third cranial nerve. Underneath the molars muscle is underneath the levator palpabris superioris is the Muller's muscle. The Muller's muscle is a smooth muscle. It is driven by the sympathetic system and it adds a little bit to the elevation of the eye. If you have already done the ptosis examination clinical skill, you would know that the Muller muscles add about 2 millimeters to the total elevation of the lid. The structure or the integrity of the lid, by structure or the integrity, I mean the shape of the lid is provided to it by the tarsal plate. And the tarsal plate is just thick fibrous tissue which provides the skeleton of the lid. It has meibomian glands. They're also called tarsal glands, and they produce sebum or oily secretion that covers the or that forms a part of the tear film, superficial most part of the tear film, and it retards evaporation so that the tears have a little bit of contact time with the eye. The posterior surface of the eyelid is covered by conjunctiva and it continues on to the lid margin and it is the opening of the meibomian glands are located on the posterior aspect of the lid margin. There is said to be an artificial demarcation at the lid margin where the skin part, which is coming from the anterior side of the lid, and the conjunctival part, which is coming from the posterior side meet. Although when you look at the lid, there is no clear distinction between the skin part and the conjunctival part. There's sort of a rough, not a rough, there's a very smooth transition between the two. So this conjunctiva is also called palpable conjunctiva or tarsal conjunctiva, and we have talked about this when we were talking about conjunctivitis. So skin, subcutaneous tissue, orbicularis muscle, the tarsal plate, together with levator palpebris superioris, mollis muscle, and then finally palpable conjunctiva are the various components that make up the lid. And this is true for both the upper lid and the lower lid. The difference between the two being that the lower lid does not have obviously the levator palpebris superioris or the mollis muscle because it does not require raising. So levator palpebris superioris and mollis muscle are only present in the upper lid, and we have talked about as to why that is, because that is the lid that requires raising. It's located superiorly. That's why it's called the upper lid. And if you see yourself blink in the mirror, you will notice that it's the upper lid that's doing most of the movement. So upper lid has the greatest contribution to the blink reflex, and it honestly needs to move the most because that's the one that also covers your eye the most. The lower lid is already resting in the limbus. The upper lid is the one that is moving all the way down to meet the lower lid, usually just about at the limbus or slightly above it. So it is the upper lid that's doing most of the job, either during the blink reflex or closing the eye, which is an important protective function. So we will talk about the muscles that are responsible for upper lid movement because that's the more important of the two lids and moves more of the two. So it has levator palpebris superioris and mollis muscle, which are the two elevators. Levator palpebris superioris, as we talked about, is a skeletal muscle innervated by the third nerve. It provides the majority of the elevation function of the upper lid. The mollis muscle adds about 2 millimeters of total elevation. It is a smooth muscle, and its innervation is derived from the superior cervical ganglion, which is, a part of the sympathetic trunk. Orbicularis oculi is the muscle that closes the lid, and this closes the upper lid as well as whatever contribution the lower lid has, and is supplied by the seventh cranial nerve. This is a close-up of the lid margin. The anterior surface of the lid is covered by skin, which continues on towards the anterior aspect of the lid margin. It has these lashes and gland of Zeiss as its appendages. Gland of Zeiss is an associated appendage. The posterior aspect of the lid is covered by conjunctiva, which is called the palpable or tarsal conjunctiva, and this conjunctiva continues on towards the inferior lid margin, towards the posterior aspect. It has the opening of the meibomian glands located in it. And the zone where the skin and the conjunctiva transit is classically being described as the gray line, but there is no line. So this is an arbitrary line, gray line. As you can see, the conjunctival part right here, which is on the posterior aspect of the lid margin, merges or transits very smoothly into the anterior aspect of the lid margin, which is covered by skin. And this line drawn here, this is an arbitrary line. There is no real line. It is being drawn by a human afterwards to show you the relative position of what is considered to be the transition zone between the conjunctiva coming from the posterior aspect of the lid margin and the skin coming from the anterior aspect of the lid margin. The transition is very smooth. It's not a very abrupt transition so that you can draw a line there. It's an arbitrary line. And these are the openings of the meibomian gland, and obviously you can see the cilia of the lashes. We'll talk about diseases of the lid margin. We've already talked about diseases of the lid margin before, so I'm pretty sure you know and have a lot of knowledge and information about these structures by now. So this is another picture that shows you the basically the tarsal plate of the lid. That's why this picture is here. And as you can see that these are the tarsal plate, this is the tarsal plate of the upper lid, this is the tarsal plate of the lower lid. In order to make things clear, let's put some landmarks. And the first landmark is the periosteum of the bony orbital margin, which is this green dotted line. This periosteum continues into both the upper lid and the lower lid as the orbital septum, which is the area between the two red dotted lines. The orbital septum itself continues on or merges into the tarsal plates, which is represented by the area between the black dotted line. And the tarsal plates of both the upper lid and lower lid are anchored to the bony orbital margins by lateral and medial. This is the medial, and this is the lateral canthal tendons or ligaments. So this is just to keep the lid stretched and also to provide support to these tarsal plates. And finally, we have the fibers of levator palpably superioris coming in to attach to the upper lid skin as well as the tarsal plate by piercing through the orbital septum. We'll talk more about levator palpably superioris when we talk about ptosis. So we'll start off by talking about ectropion, which is the first of the three lid malpositions we'll discuss, and the first of the two that involve lid margin. Ectropion is a unilateral or bilateral variable outward turning of the lid margin, which is primarily seen in the lower lid. The reason being that the upper lid tarsal plate is really strong and its facial support is also very strong. So it's not impossible to develop an ectropion in the upper lid. It's just that it is much, much rarer to see and it's generally seen in the lower lid. If you have excessive lid laxity due to a weak tarsal plate, you can develop an upper lid ectropion, but by far and large, it's mostly something that's seen in the lower lid. There are about 5 different causes or reasons that you can get an ectropion. The first being congenital. It is because you have really short skin of your lid, which is pulling the lid margin outwards. Involutional is the most common type, and this is the type which happens with age. And because with age, your supporting tissue is getting weaker, and this allows excessive laxity of the lid, which allows the lid margin to fall anteriorly. And this is something that's made worse by excessive lid pulling. You know, some people have this obsessive compulsive disorder of pulling their lid or rubbing their lid. And this rubbing action or this pulling action weakens these supports even further and would cause an ectropion. And remember, lower lid, tarsal plate, lower lid supporting fascia is already weak to begin with. Sacrificial is because of scarring on the skin side, which causes the skin to pull the lid margin outwards. Paralytic is because of paralysis of the seventh nerve. Remember, orbicularis oculi helps in closing the eye, so when it contracts or its tone helps the lid oppose itself to the eyeball. And if the muscle is not working, the lid margin can sort of fall away from the eyeball. We'll see some examples in a bit. And finally, tumors or swellings or growths can be large enough to cause a mechanical ectropion in which your lid margin can turn outwards. So this is a congenital ectropion, and as you can see right here, I can see the palpable conjunctiva, which normally cannot be seen, as we saw in the picture when we talked about normal landmarks. You can also see a little bit of the palpable conjunctiva of the upper eyelid. And that is because there is very little skin of the eyelid, and the eyelid tends to be directly attached to the cheek, or the eyelid is seemingly attached to the brow in the case of the upper lid. So there's very little skin of the lid itself, and because there is short skin, the lid is pulled excessively, which causes the lid margin to evert or fall outwards. And this is basically, these arrows are indicating that you can see the palpable conjunctiva, which you normally cannot see because it is flush against the eyeball. This is involutional ectropion, and as you can see most of the palpable conjunctiva because the lid margin has fallen anteriorly. This is because of age-associated weakness of tissue, which is further compounded by rubbing or excessively pulling the lid. One of the consequences of ectropion is that your punctum is no longer flush against the eyeball and can no longer drain the tears appropriately away from the eye. This is sacrificial or ectropion due to scarring, and this is a patient of vitriolage. And as you can see, there are multiple scars all over the face, and the scar right here has sort of fused the skin of the lid to the cheek, and you can see a very large ectropion in this area. And I'm sure you know what vitriolage is. This is the seventh nerve, a patient of seventh nerve palsy of the left side. And as you can see, there is an ectropion here. And this ectropion is simply because the orbicularis oculi muscle is paralyzed and does not have its stone. If it does not have its stone, it is no longer providing any support to either of the lids, the upper lid or the lower lid. And since the lower lid is much weaker, the loss of this support would mean that the margin sort of everts outwards. You can see other features of the seventh nerve palsy in this patient, like at the mouth and the forehead. So I'm sure you know these and can recognize this as seventh nerve palsy. Seventh nerve palsy could have many reasons. Bell's palsy, you can have trauma, you can have tumors, you can have a stroke. But one thing that you should remember is that, with the exception of Bell's palsy, most of these causes, tumors and trauma, usually involves nerves uh, in groups. So it is possible to have an isolated seventh nerve palsy, but it is usually a multiple cranial nerve palsy. So it's important to examine all of the cranial nerves that are very close to the seventh. So you examine fifth, sixth, seventh, and eighth cranial nerves because they're very closely associated in their central pathways until all of the nerves sort of start distributing to the tissues that they're supposed to go to. And the very important bit when you're looking at a patient who is paralytic ectropion is to ensure that you do your complete neurological cranial nerve examination. So this is a mass, this is a tumor, two different types of tumors which are pulling the eyelid margin away, again the lower lid, to cause ectropion. So what sort of a presentation would the patient have? Well, because of ectropion, and ectropion is basically causing two things, pulling the eyelid margin away, number one, and number two, as a consequence of the lid margin being pulled away, the punctum is pulled away. And as this usually happens more commonly in the lower lid, it's the lower lid that is no longer in position, one, and it is the lower lid punctum that's no longer flush against the eyeball. That's two. So most of the symptoms are going to be an improper blink reflex and the affected tear drainage. Now the lower lid does not have a contribution to the blink reflex, but the lower lid has to be in its position in order for the blink reflex to complete, and the lower lid's margin is no longer in its position. So you cannot ever have a complete blink reflex as long as you have some degree of ectropion. And your symptoms are just going to be that of an improper blink, which is basically a red watery eye, a red eye because the eye is exposed. It cannot close properly because the lid margin is away from the eyeball. And you have a watery eye because the punctum cannot drain the tears, number one, and because you have an improper blink reflex, your tear film stability is affected. Now, we talked about tear film stability when we talked about the the blepharitis, the anterior, posterior, and the mixed blepharitis when we were doing the first differential of this theme. So that is what tear film instability is. We talked about tear film breakup time. We talk more about tear film stability when we do the lacrimal drainage system in dry eye, which is the other disease topics in this theme, which are just going to come out after this. But ectropion causes a red eye because of exposure. It causes watering because the punctum is not in its position, so it cannot properly drain the tears away from the eyeball, and the blink reflex cannot complete properly, so you get a tear film instability and a dry eye. You have an itchy, an irritation or a gritty and a foreign body sensation because of an incomplete blink and tear film instability. And if this persists for a very long time, your eye, especially your cornea, can become dry enough so that it starts getting corneal erosions and corneal ulcer because of exposure, incomplete blinking, incomplete eye closure, that it can scar and it can lead to sight loss as well. And together with these symptoms, you're going to have symptoms of one of the causes of entropion. For example, a mass that was slow growing or fast growing, vitriolage, You would have a history of excessive eye rubbing, laxity, or old age. So there's always something that is telling you why this condition occurred or happened. Um, when you look at a patient, you'll see obviously ectropion, variable degrees. Variable degree, I would mean some patients would have a very severe ectropion, some might have an ectropion that's limited to just one part of the eyelid. For example, a tumor, as we saw, I'll just go back to the tumor slide. It's causing a very localized ectropion right here. This one is causing a larger ectropion. So the extent of ectropion would depend upon what caused it and to what extent it is causing it. We saw the example of a patient of vitriolage. It has a huge ectropion because of the scar that has fused the skin of the lid to that of the cheek. So together with the symptoms that are specific to ectropion, irrespective of etiology, you will also get symptoms of one of the underlying causes of ectropion. So variable degrees of ectropion and conjunctival congestion, which is again, as we talked about, because of exposure and dry eyes. You would also have evidence of tear film instability because of improper blink reflex. We can do tear film breakup type and Schimmer's test, both of which will be discussed in detail in the upcoming session on nasolacrimal system and dry eye. But we've already seen what a tear film breakup test looks like and how it's done. And if you have a patient who is presenting with an advanced disease, he would have evidence of corneal damage. So as we talked about before, there are certain special consideration, and we'll start off by sacrificial, in which it's very important to note the extent of scars, not only those involving the eye, but other facial features. Because you remember, your patient is not just an eye, he's an entire human being. So we need to cater to all of his presentations, not just the eye, even if you're an ophthalmologist, and especially if you're a family physician, because your job is to look after the entire family and all the members of the family and all the issues with the family. Even if they are presenting with an ocular symptom primarily, you must look for all the other issues or signs of damage associated with scarring, especially in the case of vitriolage. Paralytic, as I've already talked about, you need to do a complete CNS examination because it is possible to get isolated seventh nerve palsy, for example, in the case of Bell's palsy. But usually, seventh nerve can imply involvement of the sixth nerve, the fifth nerve, as well as the eighth nerve. So you do the entire cranial nerve examination and would require maybe some other testing as well, depending upon your findings, and even maybe radiological investigations. For mechanical, you need to figure out whether this lesion that is causing the ectropion is malignant or not. So you take the age of the patient, the color of the skin, the sun exposure, all of these things into account, because most of skin cancers are associated with Caucasians, i.e., individual with relatively low or less amount of pigmentation, old age, and with those with excessive sun exposure. So how do we manage ectropion? Well, there are journal management that you will do for all types of presentation, and then there is certain specific management which would be dependent upon the etiology of ectropion. So because it causes a dry eye, you provide lubrication, and because the eye does not close properly, you would give some form of sun protection as well. For example, sunglasses. And there are other ways as well. You can use PCAPs. If the eye does not close properly at night, you can tape it. So there are various mechanisms that can be employed to, provide some form of general management and relief to the patient, while you approach and work towards dealing with the condition that caused the ectropion. So if you have congenital ectropion, you would do some sort of skin grafting for skin shortening. Involutional is basically tightening of skin. I'll show you some pictures as to how that is done. For sacrificial, you need to release scars. You would need to have oculoplastic or a plastic surgeon assistance. For paralytic, you need to find the cause of paralysis. And you need an ENT consult or a neurology consult. And if the cause is sort of something that causes an irreversible ectropion, you can do skin tightening. Mechanical is removal of tumor together with skin graft or growth or just resolution of whatever swelling is causing the mechanical ectropion would cause the ectropion to go away. So let's talk about skin tightening. This individual has an ectropion, a very mild ectropion of the right lower lid. The eye is marked properly. And what we do first is we would excise the lateral canthus and pull the lid. And this is obviously done under local anesthesia. And we pull it until the lower lid is firmly opposed to the eyeball. And then we apply stitches and cut the excess skin off. And this is post-operative result. You can see how much better the patient looks. And this was basically more to do with cosmetics of an involutional uh, ectropion more than anything else. So the surgery is usually safe. It's usually done by general ophthalmologists, and it is mostly done by oculoplastics or plastic surgeons. You could have wound infections, overcorrection and undercorrection. Overcorrection and undercorrection is not honestly that much of a problem. It's done under local anesthesia. So you are seeing what's really happening. Your muscle has whatever tone it would normally have, because all you're doing is generally paralyzing the fifth nerve to prevent pain sensations. The aim is not to paralyze the muscles or anything. The anesthesia can diffuse there, but generally it's very superficial anesthesia to just block the pain pathways. And even if there is a correction of undercorrection, you can simply, correct a little bit more. If it's overcorrected, you can loosen some of your sutures. But honestly speaking, it's usually a procedure that is very safe, especially in somebody who has been trained in oculoplastics or plastic surgery concerning the aesthetics of the eye. Now we will talk about entropion, the second of the two lid malposition involving the lid margin, and overall second of the three that we'll talk about in this topic. So entropion is the opposite of ectropion. It is a unilateral or bilateral variable inward turning of lid margin. Now, lid margin has cilia, and cilia turning outwards together with ectropion wasn't much of a problem because they were moving away from the eyeball. One of the issues with entropion is that as the lid margin turn inwards, so do your lashes. And if the lashes turn inward enough, if the entropion is severe enough, it would cause the lashes to rub against the cornea, which would have its own issues. This inward turning of lashes is called trichiasis or trichiasis. And trichiasis can occur without entropion, but entropion is something that's almost always associated with trichiasis or trichiasis. Again, the lower lid is more commonly involved than the upper lid simply because the lower lid structures are weaker. You can get upper lid entropion, especially if you have a spastic entropion. We'll see the causes of a spastic entropion in a bit. And more importantly, trachoma. We've talked about trachoma when we talked about conjunctivitis, specifically chronic conjunctivitis, specifically chlamydia trachomatis conjunctivitis, and then specifically the condition trachoma. The etiology is somewhat similar to an ectropion, but we are just reversing all of the pathological changes. So for congenital, we have a tarsal plate that's so weak that it simply kinks or folds. I'll show you some pictures as to how that appears, but this is a very rare condition. The last literature I read has less than 50 reported cases, so it's a very rare condition. Involutional is again age-related process in which your lid support structures, the tarsal plate has become so weak that the lid can simply fold inwards. Sacrificial is scarring, but rather than scarring on the skin side, now you have scarring on the conjunctival side. And again, the example is trachoma. You can also see it in Stevens-Johnson syndrome, which is erythema multiforme major, which is, I'm sure you know what Stevens-Johnson syndrome is. Spastic is simply spasm of orbicularis oculi, and we'll see why that happens. So we'll start with congenital entropion, and it is happening because the lower lid, mostly the lower lid support structures are so weak that the lid is basically folded onto itself. So this is a normal lower lid. And this, the eyeball is right here. And this is a kinked or a folded lower lid because the support structures within the lid are very weak. So the lid basically folds on itself. So if this is a normal lid, like so, and this is the lid margin, and the eyeball is right here, the lid margin folds in like this because the tissues of the lid itself are so weak that they cannot support the lid margin. So the lid basically folds onto itself. Together with the entropion, you can also see trichiasis or trichiasis, where the lashes are now also not appropriately or not correctly directed. They are misdirected and they are touching the eyeball. So if I were to explain it in a little more detail, this is a diagrammatic representation of a congenital entropion, and the lid is drawn oversized as compared to the eyeball, and this is what happens in entropion, that the lid folds because of weak structures by birth and causes the lid margin to fold inwards. And this is the normal lower lid. These are both lower lids, the entropion one and the normal one. And as you can see, this is how the normal lower lid is supposed to be oriented. So this is involutional entropion. Again, trichiasis or trichiasis can be seen in association with it. And this is just age-related weakening of lower lid structures leading to folding of the tarsal plate, which manifests as in entropion. And you can also see trichiasis. This is sacrificial entropion, and this is the one that's associated with trachoma. You can see entropion together with trichiasis in the picture on the left, and this is the arch line, which is the band of fibrosis that leads to entropion and trichiasis, and this is seen in trachoma. You can go back and have a look at the discussion of trachoma if you would like to, have some recall. Sorry, let's say recall. This is spastic entropion. Believe you me, I could not find a picture of spastic entropion in any one of the medical resources, so I had to use a Getty's image. Spastic entropion is usually neurogenic or psychogenic in its etiology. If it's psychogenic, you need to be very careful and appropriately evaluate your patients, because psychogenic spastic entropion patients are usually young males and females who have gone through some physical abuse or mental abuse, and this is their means of escape or from the abuse, and they are simply trying to use this as a call for help. So if you see a patient who is a young male or female with a very acute history of spastic entropion or just spasm of the eyes, you need to take a very careful history. Try and talk to the patient in confidence. If the patient has a lot of relatives with him or guardians with him, try and reduce their number or talk to them individually. Remember, if you are talking to a patient of an opposite sex, you must have a chaperone, usually a nurse, a male nurse or a female nurse present with you, depending upon your own gender, so that you maintain those ethical norms. So, anyways, spastic entropion can also be because of something that's gone inside the eye, which is basically neurogenic in nature, which is because of the pain that's associated with damage to the cornea, even sort of what's the word for it? Innocuous corneal damage, which is sort of not threatening to the sight, can lead to a significant amount of pain that the patient might just go into a spasm. And if the spasm is strong enough, spasm of the eyes, it's called blepharospasm, it can be strong enough to cause entropion or inverting of the lid margin. So really just look into the causes. Some are very easy. For example, looking at electric welding, and I've seen that happen. Most of the welders in or some of the welders in Pakistan are usually young males, teenage males, who, when they experience electric welding or do electric welding for the first time, do not wear appropriate protection. We have seen that when we talked about ocular trauma or eye trauma, that those erosions in the cornea can be really painful enough to lead into a condition that is spastic entropion. But generally, it's psychogenic or in its presentation. The symptoms these patients experience are because of irritation to the ocular surface, being the conjunctiva and the cornea, because of an invert turned lid margin and the associated trichiasis. The lashes keep on rubbing against the cornea and the conjunctiva, producing inflammation, and it can also produce the corneal erosions, corneal ulcers, and eventually corneal scarring. And because the lid margin is turned inwards, the blink reflex can't complete properly, even though that this is the lower lid does need to be in its proper place for the blink to complete. the set of symptoms are also because the tear film is unstable simply because the quality of blinking is not normal or not good. So the symptoms are very similar to the symptoms of ectropion, with the difference that the lid margin is now turned inwards, and it may also have the lashes turned inward as well. The other symptoms of a red eye, a watery eye with a foreign body gritty sensation are similar to the symptoms of ectropion. The reasons are slightly different this time. You have a watery eye because of constant irritation from trichiasis or trichiasis, as well as the poor quality of blinking. We have gritty sensation or foreign body sensation again from trichiasis, those lashes, or from a dry eye because of poor quality of blinking. So essentially, between ectropion and entropion, the major differences is the position of the lashes. In entropion is turned inward, so it's causing an additional set of issues, and it has its own presentation in the form of irritation. Every time those lashes are going to rub against the cornea, they will produce irritation. You have irritation in ectropion as well, but that is mostly because of dryness. This time, irritation is because of dryness, as well as the lashes striking against the cornea and the conjunctiva. And if you have a more advanced disease, obviously you will see corneal involvement in form of corneal erosions, ulcers, or even scarring, as we saw in the case of trachoma when we were talking about conjunctivitis. And obviously you're going to have history of one of the causes leading up to entropion. Signs would be variable degrees of entropion depending upon the cause of entropion. Together with trichiasis, it is almost always associated with trichiasis and conjunctival congestion, which is because of dry eyes as well as the lashes striking against the conjunctiva. You also have evidence of tear film instability. We have talked about this when we talked about ectropion. And again, more advanced diseases would present with issues or signs which tell you that the cornea is also involved now. Special consideration here is obviously spastic entropion, and we'll talk about why that is. It could be neurogenic. If it's neurogenic in nature and the patient is giving a certain history of trauma, be very thorough in your eye examination. Sometimes it's a little foreign body that's trapped somewhere in the lid, which we have already talked about when we talked about eye trauma, which can cause enough pain at times so as to make the patient just close his eyes really tight and lead into an entropion. And more importantly, psychogenic. We have talked about it in some detail, so make sure that you take the patient into confidence, or if it's not possible for you, maybe take the assistance of a psychiatrist or a psychologist to ensure that you are doing your best to help your patient. So remember, always take help if you are unsure, because your patient's best interests should always be your top priority. Management of entropion is a little more involved as compared to ectropion, because this time we have to take into consideration trichiasis. So we do start off with lubrication, and lubrication is important because of a tear film instability, and B, this time those invert and lashes are providing more irritation, so that lubricating tear film does provide a sort of a barrier. And if you can use non-preserved tear film for extended periods of time with very frequent dosing, it does help. We can also do taping as a temporary relief measure, and what you do is you put some surgical tape on the outside so as to pull the lid margin away from the eye. It's usually useful when you know that you only require a temporary measure, for example, a spastic, mild spastic entropion. Epilation is a very useful procedure in entropion because it helps you to get rid of those lashes, which form a very major component of irritation to the patient. So you can use mechanical, simply physically pulling them out. You can use an electrode to burn the root or the follicle, and also use cryo. Cryo provides the most long-term relief of the three methods listed here. There are other methods that can be used to do lash epilation. Specific measures would involve, obviously, specific etiologies. For congenital botulinum toxin, repeated injections, if that's not feasible, wedge resection. For involutional, you can use something called Quickert procedure, which is transverse everting sutures, which are sort of anchors that pull the lid outwards, or wedge resection. Sacrificial would involve release of scars, and spastic, really important to figure out the cause of the spasm and botulinum toxin injection. Again, you would need to do multiple injections of botulinum toxin until obviously the resolution of the spasm. So these are your everting sutures, and what they do is they provide an anchor to the lid. I'll show you a video for a better understanding of how this is done, but basically you enter through the palpable side, pass through the tarsal plate, and you stitch or suture up from the skin side so as to pull the lid margin outwards away from the eyeball. So we are approaching from the palpable side, close to the lid margin, and passing through the lid substance, including the tarsal plate coming out from the skin. And then we will do it again, like so, so as to create an anchor which will pull the lid margin out. And then we just tie up our suture here. And we applied 3 equally spaced sutures so as to pull the lid margin outwards. It's pretty effective and relatively easy to do. Here we go. Inverting sutures, quickest procedure. This is going to be a video on wedge resection, and wedge resection is basically taking a wedge out of your tarsal plate so as to shorten it up a little bit and then stitch it. So as we are shortening the tarsal plate, we are actually pulling the tarsal plate we are pulling the tarsal plate in a way so as to move the margin of the lid away from the eyeball. So this is right eye wedge resection, as we will see. This is not my video. This is Dr. Santosh. This is where he will incise. This is the upper lid, in all likelihood secondary to trachoma. This is skin incision. This is a pottery that is being used. And this is how he's resecting the tarsal plate. So he's cutting the tarsal plate, uh, and now he is suturing the 2 ends of the tarsal plate. He has removed a wedge section from in between, and as these sections are sutured up, it sort of strengthens the tarsal plate because it's shorter, and these sutures are providing additional support. So finally, the skin is sutured after suturing the resected tarsal plate, and you can see how much of an improvement there is. The lashes are all appropriate, and there's a lot of symmetry between the 2 eyes now. Surgery is again relatively safe. You need oculoplastics or a plastic surgeon or well-trained ophthalmologist, general ophthalmologist who's done a lot of these procedures to get the best results. You can get wound infection, and you can again appropriate antibiotic and NSAIDs can handle it, and over and under correction is basically redoing the procedure. Quicker reversing sutures are easier because you can simply remove a suture if it's overcorrecting. If it's undercorrecting, you can apply a suture with a little bit more strength and tension. So before we go on talk about ptosis, which is the last of the lid malpositions, because we've already completed the 2 malpositions associated with the lid margin, it's important to talk about these 2 conditions and differentiate. Trichiasis or trichiasis we've been talking about is an inward turning of the lashes towards the cornea. It is seen in association with entropion, but can also occur without it, in which only the lashes are turning inwards. Distinctis is usually a congenital condition, and it's usually an autosomal dominant condition. It can also be an acquired condition in which you have an extra row of eyelashes or an extra set of eyelashes that are emerging from the openings of the meibomian gland. So they're coming out of the posterior lid margin. These lashes can be really fine and produce no problems for the patients, no symptoms, or they can be coarse and rough and can be very much like, in terms of their effects, like trichiasis or trichiasis that in the sense can cause corneal erosions, ulcers, and even corneal scarring. So this is what trichiasis is. This is inward turning of the normal lashes. And this is what distinctis is. As you can see, these are the normal lashes that appear from the anterior lid margin, and these extra set of lashes are appearing from the posterior lid margin opening of the meibomian glands, and this is distinctis. So trichiasis is your normal lashes turning inwards. Distinctis is an extra row of lashes which is coming out from the posterior lid margin from the openings of the meibomian glands. And they can be fine and small and cause no symptoms, or like this, but they can be constantly irritating your eyeball and your cornea and be responsible for a lot of irritation and in long term, without proper management, corneal erosions, ulcers, and even scarring. Now we are going to move on to our final lid malposition, which is ptosis or blepharoptosis. It's the most important one as well. Before we talk about ptosis, let's just quickly go over the upper lid elevators. We had levator palpably superioris, which arises from the orbital apex. It inserts into the upper lid skin as well as the tarsal plate. And as it inserts into a skin, it produces a skin crease, and that crease is telling you, or a lid crease on the upper lid skin, just telling you that the levator muscle properly developed and properly developed and is properly inserted into the skin. It's a motor muscle, a skeletal muscle innervated by the third cranial nerve, and it is the one that is providing the majority of the elevation action of the upper lid. The molars muscle, it is also called the tarsal muscle, is a smooth muscle. It arises from the undersurface of the levator palpably superioris, and it inserts into the tarsal plate. And it provides about 2 millimeters of elevation, so it's a minor elevator. It's a smooth muscle. It's getting its innervation from the superior cervical ganglion, and that's driven by the sympathetic system. We're going to see a little animation that will help us sort of identify with the levator palpably superioris. Before we begin the video, I'll show you some landmarks. This is the orbital septum, this whitish creamish colored structure which arises from the periosteum of the bony orbital margin. These gray structures are your tarsal plates, and they are anchored to the bony margins by medial and lateral canthal ligaments. We have seen this in the diagram before. These are the fibers of the levator palpably superioris, and as it comes from the orbit, it pierces the orbital septum to attach to the tarsal plate. It also attaches to the skin of the upper lid. We have sort of dissected those layers away, thus you can't see them. We'll start the animation, and we'll just look at how this muscle approaches the eyelid. In order to do that, we would need to sort of remove the orbital septum out, which we'll just do. So this is the levator palpably superioris, attaches onto the tarsal plate. We'll remove the roof of the orbit, and this is how it travels from the orbital apex, from its origin, all the way to its insertion onto the tarsal plate and to the skin of the upper lid. So this is levator palpably superioris, and this is the skin crease it produces because it attaches some of the fibers of the levator palpably superioris, or more appropriately, the aponeurosis of the muscle attaches to the skin to produce this lid crease, and it also obviously also attaches to the tarsal plate. Ptosis is defined as an abnormally low upper eyelid margin when the eye is in a primary gaze. You know, I'm looking like this and this. I'm trying to say where the camera is. I record on different devices, and the location of the camera is everywhere. So my apologies if you see my eyes moving around when I'm reading, because I'm trying to remember where the camera is. So it's an abnormally low upper eyelid margin when the eye is in a primary gaze, i.e. looking straight, because you know when you move your eyes, your lid tends to follow the eyeball. So when you are assessing ptosis or examining ptosis, it's always when the eye is in a primary gaze and you're looking for the position of the upper lid margin. It is classified into a congenital and an acquired variant. Congenital variants are by far the most common type. And we'll start off with the congenital variant or congenital ptosis, and the etiology is here. The most common reason for a congenital ptosis is levator maldevelopment, which is a type of myogenic ptosis, i.e. related to the muscle, levator palpably superioris, or the other one, the Muller's muscle. So the most common reason is levator maldevelopment, which is obviously could be bilateral or unilateral. Unilateral is something that's much more commoner. If it is bilateral, it can be asymmetric. One eye can have more ptosis as compared to the other. The telltale sign of this ptosis is that the amount of ptosis would remain constant because the amount of maldevelopment would obviously stay the same as long as the patient is alive. The other cause of myogenic ptosis is trauma, and this is birth trauma associated with the difficult or an instrument delivery, which causes direct damage to the the levator palpably superioris muscle. So that would be something that is by birth, since technically this happened during the process of birth. Neurogenic doses is damage to either the third nerve, which is the nerve that supplies the levator palpably superioris, or it is damage to the supply of sympathetic innervation to the molars muscle, which would be congenital Horner syndrome. A mechanical is simply a tumor or a mass, like hemangioma, that is forcibly closing the lid down. Marcus conjovincing is very interesting. It's a unilateral, non-hereditary condition in which the fifth nerve supplies the levator palpably superioris. So every time your muscles of mastication contract, the levator contracts and you open your eyes, and when those muscles relax, the eyelid closes. So your eye sort of winks when your jaw moves. I'll show you a video. Very interesting. And you can have a syndromic form in which you have multiple conditions all together in one sort of a syndrome. One is called Karen-Sayre syndrome, which is retinitis pigmentosa together with ptosis, and you lose the ability to move your eyes as you grow older. So extraocular muscle function sort of is lost progressively, and that is all of these things are happening because of a mitochondrial anomaly. So this is a type or a picture showing you an example of myogenic doses, which is levator maldevelopment. Notice the absence of crease, and this crease is absent because the levator never developed properly. It never inserted into the skin, so you don't have the crease. And this is a picture showing you what a normal crease looks like. And obviously, since this is a congenital condition, your patient is almost always going to be a child unless you have a patient who had this as a congenital disorder but only went to a doctor later because of non-availability, or he has been going to a doctor's and he just decided to sort of come again, never got treatment as a child. This is a rather interesting picture, and there are no labels or captions to it because I want you to study it and tell me what anomalies do you see. Just spend a couple of seconds on it. Yeah, well, okay. If you did, very good. Let's see how many of the anomalies you picked up. The first thing is the color between the two eyes is different, and that is because the color of iris is different. The other thing is the pupillary sizes are different. This pupil is larger, this pupil is smaller. The third thing, if you've picked up, the lashes on this side have more color to them as compared to the lashes on this side. That's the most subtle of the differences. So which eye is normal and which eye is abnormal? Well, this eye is abnormal because the difference that is telling what condition is this is the only thing haven't disclosed yet, and that there is a very mild ptosis in the left eye. And all of the things that you see in the left eye are because of one condition, and they explain all of these things: the color of the iris, the small pupil, the relative difference in the color of the lashes, as well as the ptosis. This is an example of congenital Horner syndrome or Horner syndrome. And the color of the iris, which is called heterochromia, difference in color of the iris, is because the sympathetic innervation to the eye was never completed. And sympathetic innervation is essential for the pigment to develop. And that's the lighter color of the iris and the lighter color of the lashes. The pupil is small simply because the dilator pupillae muscle is driven by the sympathetic system. And again, that muscle is not working. So the sphincter pupillae is the only muscle in the pupil, and its action is making the pupil smaller than normal because there is no contra action or the opposing action of dilator pupillae, because dilator pupillae is not working because the sympathetic stimulation to the eye was never completed. So the small pupil together with the light colored iris are both explained by lack of sympathetic stimulation, sympathetic innervation to be more precise, as the color of the lashes. The ptosis is because of the same thing. Muller's muscle is not working, and Muller muscles provide about 2 millimeters of elevation. So this is a very mild ptosis, just about 2 millimeters. We'll do some measurements of ptosis. We'll talk about them here very briefly. We have an entire presentation on the clinical examination of ptosis. You can refer to that video for more details. So let's bring in some of those labels. Mild ptosis, remember Muller's is only providing 2 millimeters of action, so this is just 1 millimeter of ptosis. Heterochromia, anisocoria, meaning difference in pupillary size, and this is because all of these things are because of lack of sympathetic innervation. So Horner syndrome can be central, it can be preganglionic, and it can be postganglionic. A central Horner syndrome is when there is something wrong with the central sympathetic nuclei, and this would cause anhydrosis that is complete all over your body. And one example of a cause of central Horner syndrome is encephalitis. A preganglionic Horner syndrome is something in which the damage exists before the superior cervical ganglion, and you'll get facial anhydrosis, so it's more localized now. And one of the causes is trauma, the other is Pancoast tumor. Pancoast tumor is tumor of the apex of the lung. Postganglionic is fibers that are specifically directed towards the eye, so you don't have any anhydrosis, eye doesn't sweat. And the causes of that is damage to the fibers going to the eye, which is cavernous sinus thrombosis or carotid artery dissection. I'm sure you know the pathway of the sympathetic flow to the eye better than I do, and you can associate cavernous sinus thrombosis or carotid artery dissection with loss of sympathetic innervation to the eye. So this is the sympathetic flow from the posterior hypothalamus all the way to the eye, and this is the area of damage in central Horner syndrome. This is the area of damage in preganglionic Horner syndrome, and this is the area of damage in postganglionic Horner syndrome. As you can see, if the damage is central, almost all of the sympathetic supply to the body would be affected. If it is preganglionic, we are talking about fibers that are destined for the superior cervical ganglion. So only the area which is covered maybe by superior cervical ganglion is affected, facial anhydrosis. And we talk about postganglionic, we're talking specifically about fibers going to the eye. This is mechanical ptosis. You can see a large strawberry hemangioma causing ptosis. And the biggest repercussion of ptosis in a congenital setting is amblyopia. And this amblyopia is very similar to amblyopia because of cataract, which was called sensory deprivation amblyopia or vision deprivation amblyopia. And sorry, in cataract, it was because the cataract was obstructing light from reaching the retina. Here, it is a lid that is obstructing the visual axis from obstructing light from reaching the retina because the lid is obstructing the pathway because it's covering the visual axis. Obviously, not all congenital ptosis would be severe enough to cause vision deprivation, but any congenital ptosis that's covering the visual axis can potentially lead to amblyopia if not managed in time. So I put the definition of amblyopia here for those who had sort of probably forgotten it by now. And it's just that your cortex is inhibited from receiving visual signals from the affected eye, resulting in poor vision for that eye simply because the retina is not stimulated enough. And this always occurs in a disease that is congenital or very close to the childhood, because once you are beyond a certain age, about 9 to 12 years, the visual pathway is fully developed, and unless you have physical damage to the pathway, that pathway really can't be shut down. So this amblyopia is something that's usually almost exclusively seen in children. So the patients of ptosis usually present with variable amounts of drooping of eyelids, and the complaint comes from either parents or guardians or the patient themselves if they are old enough. And older photographs here are something that are very useful because it tells you when was the ptosis noticed and is the ptosis variable. And the signs of ptosis that you would see and the history that you would get from your patient would again depend upon the causes or the reason that the ptosis developed. So obviously you will see variable amount of ptosis together with signs of associated conditions. For example, if you have idiopathic myogenic doses, you would have an absence of lid freeze together with a very stable ptosis. If you have neurogenic Horner syndrome, you would have facial anhydrosis, anisocoria, that is difference in pupillary size, heterochromia, together with a very mild ptosis, because Muller's muscle that is supplied by the sympathetic system provides about only 2 millimeters of elevation to the upper lip. Then you have Marcus conjowl winking, that is ptosis associated with chewing, and mechanical ptosis would have an associated mass or a tumor that you could see. Decrease in vision is something that could also be a sign, and that would depend upon the duration of the ptosis, the severity of the ptosis, if the upper lid is covering the visual axis. So this is again a sensory amblyopia that is the cause of decreased vision in this case. So let's talk about acquiatosis before we talk about management, because management is something that we can sort of group together. Acquiatosis is something that you get because after birth, and the causes are sort of similar to congenital doses, except for that the setting is different. We have a myogenic variety, which is uh, could be involutional, which is age related. So with age, what happens is your muscles is getting weaker, and the levator simply disinserts from the upper leg. Remember, it inserts into the tarsal plate as well as the skin. It could disinsert, and that is simply because of weakening. And this is especially if you rub your eye too much, or you pull your eyes too much, or some other form of eye trauma. It can also be direct traumatic, in which you have road traffic accident or some other type of accident, which is directly causing trauma to the muscle, irrespective of age, and causing ptosis. You can have neurogenic doses, which is damage to the nerve. Here we have third nerve palsy, which could be because of many reasons. There are tumors, there is stroke, there is trauma. And if you have problems in the central nucleus, if the etiology or the lesion is in the central nucleus, you have bilateral doses. Because although the levator is supplied by the third nerve nucleus is unpaired. There is one nucleus for both levator palpably superioris. That is why it's so difficult to wink, and winking is an acquired art because there's only one muscle, one nucleus covering both levator palpably superioris. So it is sort of like requires a little training to, make one levator palpably superioris contract while the other stays open, and you don't have to, produce a mouse gesture to do it. You can have myasthenia gravis, which is basically a disease of the motor end plate, and it's very classically variable. It's more towards the end of the day rather than in the beginning of the day. And it's also associated at times with diplopia because together with the levator palpably superioris, you can have an issue with one of the other extraocular muscles. So the movement of the eye is also affected. You can have acquired Horner syndrome, which is tumor or trauma. Tumors would be Pancoast tumor. It's a tumor of the apex of the lung, which is sort of in approximation to the cervical sympathetic chain in the location of the superior cervical ganglion. You can have mechanical ptosis, which is again a tumor or a growth which is acquired. And finally, an acquired Marcus-Gunn jaw winking, which is usually post-traumatic misdirection of the fifth nerve. So this is levator dehiscence, acquired ptosis, involutional ptosis. As you can see, we have ptosis of the right eye. The left eye is showing an ectropion as well. And again, this is involutional ectropion because of age. And the patient is using or trying to use the effect of the frontalis muscle to open the eye. This can be seen because the brow is higher. The brow is higher because the patient is using the effect of the frontalis muscle or the mechanical effect of the frontalis muscle because the skin of the forehead continues as the skin of the upper lid. So when you contract your frontalis muscle, you can sort of open the eye a little bit. You can also notice the absence of a lid crease, and the lid crease is simply absent because the levator disinserted as it disinserted from the tarsal plate as well. This is third nerve palsy, and this is a third nerve palsy because you have ptosis. And if you see here, the patient has been asked to look up, and this I can't even rotate upwards. So this is a third nerve palsy involving not only levator palpably superioris, but some of the other extraocular muscles. And again, the brow is elevated because the patient is trying to use the effect of the frontalis muscle to open the eye. This is acquired Horner syndrome. The eye color is the same this time because there was no problem of innervation at the time of birth, so the pigmentation could complete whatever pigmentation had to complete. This is a lightly colored individual, so both eyes are of the same color. Anisocoria is present because the dilator pupillae of the left eye is non-functional because the sympathetic innervation is not coming in anymore. For tumors, trauma, we talked about Pancoast tumor as one of the reasons. So this pupil is smaller because of unopposed action of sphincter pupil, the left pupil. And you see Malpositions again. Remember, it's the Muller's muscle which only provides a limited amount of elevation of the upper lid, so you don't get too much of a ptosis, just a Malpositions. This is mechanical. This is because of a bruise. So what is the presentation of an acquiatosis? Again, you have drooping of the lid together with history of associated condition, and this drooping is also of a variable amount. The signs you see are ptosis, and you might see decreased visual acuity if this ptosis was at an age where sensory amblyopia can occur, usually less than 5 years of age, because remember between 7 and 9 or 9 or 12 years of age, your visual system is completely developed. So this acquired ptosis has had to occur when the child was about 5 years of age. Trauma could be one cause of an acquired ptosis in a young individual. Other presenting features would be dependent upon the underlying cause of the ptosis. For myogenic doses, involutional would be absence of lid crease. For third nerve palsy, you could have restricted ocular motility, as we saw. For myasthenia gravis, you can have variable ptosis that changes during the day. Diplopia, because if the levator is involved, any one of the other extraocular muscles can be involved. And general muscular weakness. And again, all of this would get worse as the day progresses because of the way this disease works. It's a motor neuroclade disease. Horner syndrome is, again, a very mild dosage together with anisocoria, no change in color of the iris, but you might have anhidrosis depending upon where the damage is. Marcus jaw banking would have history of trauma, and the patient would say, oh, I was fine until this trauma happened, and I got this after that, after the trauma, after the fact. So for both congenital ptosis and acquired ptosis, there are certain things that the patient can do involuntarily at times to improve the ptosis. We saw some here as an example of acquired ptosis where the patient was using his brow to open the frontalis muscle to open the lid, which was manifested by a raised level of the brow. So that is the first compensatory mechanism, is elevation of the brow to use. That is because the frontalis muscle is being used to open the eye. The other is, very interestingly, a high resting upper lid in the unaffected eye. And that also makes sense because remember we talked about there is only one nucleus for both levator palpebris superioris. And if you have ptosis in one eye and it is because of either a congenital or a required reason, the central nervous system would send impulses to the third nerve nucleus responsible for elevation of the lids. And if it can't elevate the lid, it would send even more impulses. The muscle, the eye with the ptosis won't respond because it has a ptosis. It could be neurogenic, it could be myogenic, but it won't respond. But the contralateral eye, which is okay, would respond to these additional stimuli by raising the position of the lid higher than normal. So your lid in the uninvolved eye would be higher simply because it's getting too much stimulation, and that too much stimulation is flowing to both eyes because there is only one nucleus, and that nucleus just sends out impulses, and that impulse is then going to both eyes because there's only one nucleus rather than a pair of nuclei, one for the right, one for the left levator palpebris superioris. There's only one nucleus, and that's actually a good thing because that maintains certain level of symmetry in your eyes. So how do we know that what we are looking at is actually a higher than normal resting place in response to more stimulus? Is simply you open the ptotic eye with your finger, and that would get rid of the additional stimulation that is coming from the central nervous system because the eye that was ptotic is now open because you're forcing it open. So it doesn't need all that stimulation. So the other eye, the unaffected eye, which was actually higher because of extra stimulation, now does not need to be that higher because it's not getting that additional stimulation. So it will come back to its normal place, or more commonly would become ptotic because it was receiving such a lot of stimulation. It was so hyper excited and raised that as soon as that innervation, additional stimulation is withdrawn, not innervation, additional stimulation is withdrawn, it becomes ptotic, which is very interesting. This is also called a Heron's phenomenon. And that's simply because the neural stimulation decreases as you forcefully open the ptotic eye so that the additional impulses that were coming in don't come in. And the unaffected eye, which was higher than normal because of all those additional impulses, now falls to a normal or more commonly to a slightly more ptotic position. It sort of recovers within a few seconds, but you can actually see this happening. Very interesting. So this is what it is in terms of higher than normal upper lid resting position. This is a ptotic eye. And the central nucleus is sending impulses to both. The central, I mean the unpaired central nucleus for levator palpebris superioris is sending impulses to both the muscles. One is not going to work, obviously, but the other one, in response to additional impulses, will open even more. And you can see the superior limbus. Normally, you can't because the upper lid covers the upper 2 millimeters of the cornea. But if I raise this lid, this would become ptotic more commonly or return back to normal. But that would just be for momentarily, because the eye would take on its normal, the levator, the upper eyelid would take on its normal position in a few moments. So what sort of investigation and examinations do we need to do before we move on to the management phase? And again, this is very similar for congenital and acquiatosis. We might need some imaging, especially if there is a neurologic cause. For Horner syndrome, we need X-ray chest because of Pancoast tumor. For myasthenia gravis, electromyography or ACH receptor antibodies might be indicated. And these are ptosis examination. Again, more details in the video, which is for ptosis examination. But the amount of ptosis is determined by how much of a distance you have between the center of your pupil and the upper lid margin. If uh, mild ptosis is defined as you have an adequate space between the two, about 3 millimeters. If it's about 2, it's moderate. If it's less than 2, it's called severe ptosis. So that would more details in the video. You can refer to that. This is how much the levator muscle can elevate the lid. And what you do is you put your hand on the brow, ask the patient to look down, and then look up. You're putting your hand on the brow so that the patient does not use the frontalis muscle. Bell's phenomenon is something very interesting, and this is again this called a vestigial reflex. Like your appendix is a vestigial organ, or like wrinkling of your fingers is a vestigial reflex. Vestigial reflexes are those that were once important and are not right now that important. Your hands wrinkle in response to water is because when we were living in caves, we depended on stones and spears to defend and kill. And if it was raining, those stones and spears would slip from our hands. So our hands decided to learn to wrinkle to increase grip. I'm not joking. So Bell's phenomena is when something is really coming at you at a very fast pace, for example, a rock or a sphere, you would want to close your eyes suddenly and your corneas would rotate upwards so that whatever is fast approaching your eye, if it would hit your sclera, if it would at all, because you've closed your eyes. And your cornea is more important because if cornea loses its clarity, you lose vision. That is why they rotate upward. Since nobody throws stones and rocks anymore, hopefully this phenomena is become vestigial. Jaw winking again, just to see if Marcus and jaw winking is present. And corneal sensations are important because when you do ptosis surgery, sometimes the eyes don't close properly at night. There's a little bit of slit left. At times, this does improve with time after surgery. But if there is a little bit of slit left, it can cause dryness of the cornea because TFN production is much reduced at night. And if your cornea is insensitive, your cornea does not respond to it, this dryness, you won't feel it. And that can cause corneal erosions and ulcers. So corneal sensations are also important to check. Again, more details about these in the video. Please do see that video in association with this session. So as to get a better understanding of how ptosis examination is done and what is the relevance of all of these various examinations that are done when looking at a patient of ptosis. We'll not talk about management of congenital and acquired ptosis together because the procedures are sort of similar and they're dependent upon the amount of levator function that the patient has. And there's also a little bit of consideration of the age of the patient. So for myogenic doses, which is the most important type in a congenital ptosis, it would require urgent intervention if visual access is covered, i.e. it is possible to get uh, sensory amblyopia or vision deprivation amblyopia. Otherwise, you can wait until the eye and the adnexa is of adult dimensions. Simply because after surgery, your eye can close properly. Or if you do surgery to a child, as the child would grow older, the eye would become bigger, so the eye might not start closing properly because your surgery was done keeping in mind the child dimension of the eye rather than the adult dimension of the eye. So if you can wait, it's better to wait. It's something that needs to be explained to the parents or the guardian or even to the patient, him or herself. If you have better than levator function, it is the procedure to do is called levator resection. We'll see how that is done. If you have poor levator function, doing surgery to the levator muscle usually does not yield satisfactory results. So what we do is we create a physical connection between the frontalis muscle and the lid so as to increase the advantage of the frontalis muscle in elevating the lid. We have seen patients, and it is a compensatory mechanism to use the frontalis muscle to raise the lid. If you have involutional doses, which is an acquired type of myogenic doses, just repairing the levator aponeurosis, reattaching it to the skin and the tarsal plate works. This is how levator resection is done. So this is the skin side of the lid. This is the orbital septum. This is the levator aponeurosis. This is the levator muscle, and it's attaching to the tarsal plate and the skin. We incise the skin, separate the fibers of the orbicularis oculi, incise the septum because incise the septum. We're not removing it; we're just cutting through it. To get to the levator aponeurosis. Once we are at the levator aponeurosis, we cut it, and what cutting does is shortens the aponeurosis, which increases its pull so that it can open the eyelid more. Once we have shortened it, and there are tables that tell you if you have this much doses, mild doses, moderate doses, severe doses, this is the amount of resection to do. Once you have resected that amount, you stitch it back to the tarsal plate, close your wound, and that is it. A frontalis sling is done by using a suture or facial ara, this facial adder from the same person, and creating a physical connection between the frontalis muscle and the tarsal plate of the lid. So what you do is you give an incision in the forehead and you take your suture or your facial adder subcutaneously all the way down in a diamond-like pattern to the lid where you pass it through the tarsal plate. And this path right here where the cursor is or the arrow is through the tarsal plate, move it out into subcutaneous tissue of the lid to the forehead, bring it back where you started from and tie it together here so that now when the frontalis contracts, it can exert its mechanical force to the eyelid through this suture tract that has been created. Surgery in good hands is very good, and you would require an oculoplastic surgeon or a plastic surgeon, and they're very good at it. Overcorrection and undercorrection, really overcorrection is more of a problem. Undercorrection is maybe a cosmetic issue, mostly because a millimeter or so, a difference between the two is considered as good, but some people would be even conscious of that. Overcorrection is a problem simply because if you have over opened the eye, it won't close properly at night, and which would lead to a drying effect. And that drying effect would require taping of the eye or some lubricating ointments or surgical correction if it doesn't resolve. Usually it does with time, but if it doesn't, you would need surgical correction. For mechanical ptosis, removal of the mass usually results in resolution of the ptosis. For neurogenic ptosis, myogenic, it's usually medical management, parasympathomimetic drugs. For third nerve palsy, if it's congenital and if your visual axis is blocked, again, you need to do surgery quickly, until you can wait in teens when the eye and the adnexa is of appropriate dimensions, adult dimensions. If it's acquired, third nerve palsy, you wait for enough time so that the nervous system can repair as much as possible, which is about 6 months, and then do surgery. And since the levator is nerve is non-functioning, the levator function is usually poor, and frontalis sling is the procedure to do. Thank you very much. This is rather a short topic, but it is a rather interesting topic as well, I'm sure, as you have seen. If you have any questions, you know where to ask, and I'll see you in the next video session. Bye-bye.